All right, let's get started. Thanks everybody for joining today. I'm Rahul Mainra. I'm a transplant nephrologist in Saskatoon and chair of the CST Education Committee and part of a team that's helped to organize this Red Hot series for our fellows and trainees in donation and transplantation, which is wrapping up. Today is the last online series for the Red Hot program. And the next session will be in Vancouver at the CST Fellows Symposium. So hope to see everybody there. We've got a great morning workshop organized for you guys. You'll get some details in the near future, but we'll be looking at having all of our fellows and trainees break up into groups. We'll provide you with random research questions, and you'll be working within your groups with some very esteemed mentors helping you design your study. So I'm sure it's going to be a fantastic session, but before that, we have a wonderful session today run by Manuel Escoto from the Canadian Donation and Transplantation Research Program. Manuel leads collaborative initiatives at the CDTRP that amplify lived experiences and drive evidence-informed practices to improve donation and transplantation outcomes nationwide. He is deeply committed to advancing equitable, patient-centered healthcare systems. And today, Manuel is going to be talking to us about the really important topic on knowledge translation and knowledge mobilization. So if everybody could please mute their mics, and we'll have time at the end for questions. You can either put your questions in the chat and we will get to them by the end of the session, or at the end of the session, you can raise your hand, take your camera, put your camera on, and ask your question. So I will hand it over to Manuel. Thank you again, Manuel, for doing this really important session for us.
Thanks for having me. Welcome, everyone. And of course, thanks to you, Rahul, Francis, and Rob for organizing this and giving me the opportunity to present with the Red Hot webinar series. As was mentioned, my name is Manuel Escoto, and I lead the Patient Family Donor Partnerships and Knowledge Mobilization portfolios with the Canadian Donation and Transplant Research Program, so CDTRP for short. You'll see we love our acronyms in this presentation. Today, we'll explore how integrated knowledge translation, or IKT, and knowledge mobilization are important tools to not only improving your grant applications, not only improving your research, but also improving health outcomes for transplant patients, families, and organ donors to help improve uptake, to help improve knowledge dissemination for all partners involved in Canada's donation and transplant ecosystem. Let's advance my slide there. So I do have quite a bit packed into today's session, depending on your level of experience with either IKT or knowledge mobilization. Some may be new. I hope some of it resonates with some of the practices that you've already put in place, but ultimately, I hope that you leave here with a better understanding of the role of IKT and knowledge mobilization in research. Learn a little bit about CDTRP's own practices with IKT and knowledge mobilization. You'll learn strategies of how to apply this work into your own research. And I'll end by sharing a couple of case studies of how CDTRP and, of course, the network of researchers, patient family partners, and community organizations that we work with have adopted these principles into projects that we are actively working on. So maybe I'll start with some of the basics and some of the fundamentals of discussing what I mean by these different terms. There's a lot of terminology that's being thrown around today. And really, when I talk about integrated knowledge translation, or IKT, it's really what I'm getting at is talking about an approach that shifts how we think about research, how we generate research, how we use knowledge, and how we disseminate that knowledge. It's different than what we've perhaps been used to doing. It's different than your traditional engaged research, where we, or you folks, I should say, as researchers, as clinicians, as academics, work within your own respective institutions. IKT is really about disrupting that model It's about making the process collaborative from the very beginning. In IKT, a big focus of this strategy, of this framework, is embedding knowledge users, whoever that may be, whoever your partners may be, but embedding those knowledge users across a research cycle. And when I say that, when I say embed knowledge users, what I really mean by this is ensuring that your knowledge users, be they community organizations, patient partners, people with experiences, decision makers, and anybody who might be impacted by your work, are embedded in your research across all stages. This means that they have an active role in identifying your research questions that reflect real world needs and real priorities of communities. It means co-designing, that your knowledge users will help co-design studies, will help on recruitment methods, on outcomes and approaches that, again, are meaningful to your partners involved. It also means your knowledge users are part of the interpreting of that data. What does this data tell you? What is this data sharing? By including a different variety of knowledge users, it's really about bringing different perspectives to what this collective data means. And of course, through these approaches, it's about moving evidence into practice. So this image represents the cycle of research, from priority setting all the way to evaluation and quality assurance. Now, one of the things I always like to emphasize when I give this sort of presentation is really reinforcing the fact that, research doesn't work in a straight line. It's a continuous loop, it's a continuous cycle. But what we're hoping to do is build from one stage to another, build the learnings, building the priorities that we've heard from one stage to another. Um, both IKT and knowledge mobilization isn't something that just happens at the end. And again, we should really put that lens across all the cycles that you see here. For example, when I talk about priority setting and planning, it's really about integrating knowledge users into trying to understand, trying to define what questions we want to ask and why those questions matter. So again, whether your knowledge users are patients, families, clinicians, community organizations, policymakers, what I'm trying to emphasize this here is that integrating them at this early priority setting stage and giving them a voice will make sure that your research or your grant application is really reflective of real world needs. And I think this is especially important when we talk about marginalized communities that have traditionally faced systemic barriers into whether it's accessing resources, accessing healthcare, or being involved in research, is making sure that they have a voice at that table to not further perpetuate that cycle of not being involved. So when I talk about development of the research proposal, again, once priorities are set and teams develop the proposal, the plan, whether that's your grant application, knowledge users can help you by helping shape that study design, by helping ensure that the methods that you're proposing are feasible and are culturally appropriate, and they identify what outcomes might matter to most to the community that you're studying. When we look at the box there, that scientific review, the proposal here is really to ensure that the quality of research that you're doing meets that scientific rigor. And here, knowledge mobilization plays a role by framing questions and framing research where, again, we can highlight the real world value, whether that's addressing a community issue or a health system gap that's ongoing. With respect to ethics review, of course, we all have experience with ethics and research boards. And here, knowledge users can help you by identifying the ethical consideration that sometimes we might overlook or researchers might overlook. Are there cultural sensitivities? Is what you're proposing relevant? Is it meaningful to the community and population that you're studying? And by engaging knowledge users throughout this whole process, and therefore engaging research participants, we're reinforcing that cycle of trust and accountability. When I speak about oversight and communications, again, here it means ongoing communication with your partners, not just updating at the end. And this piece is really key. There's going to be a theme here about partnerships and relationship building. And here, this piece is really key because it's about being transparent. It's being transparent about your progress. It's being transparent about the challenges that you've experienced in your research proposal, how things change. We've all worked in projects where things don't look like they look when we first proposed our research. But it's about sharing that communication. It's about sharing how things have adapted. This is important because, of course, depending on your type of research, we're going to be recruiting participants. And this is where knowledge users and specifically community partners play a role. Our community partners are the ones who have perhaps daily interactions, that ongoing trust with participants that we're hoping to recruit. and especially those from marginalized communities. So by involving knowledge users in your research cycle, you're helping co-create recruitment materials and strategies that are relevant, that are accessible, and of course, hopefully, um, culturally safe. With respect to data collection, knowledge mobilization here ensures that it's respectful and it's responsive to participants' needs. Your knowledge users can help you provide feedback on the experiences of participants. And then as we shift through the data analysis and interpretation page, it's really about making sense of your findings. What is your data telling you? What is your experience telling you? And the reason I like to highlight that knowledge users over and above, your lead PI, for example, is needed in this work, it's because you're making sure that you have multiple lenses, multiple levels of expertise, reviewing this information and really ensuring that it's meaningful and it goes beyond just academic circles. Communities, of course, can help shape what story you're trying to tell, what message you're trying to tell, why the work that you're doing is so important. We go into the knowledge exchange and translation box there. And here, this is where research moves into action. This is where we now start thinking about those knowledge translation products that we often work on. Is it tools? Is it resources? Is it policy? Is it a policy change that we're trying to actually do? So within this level of the research cycle, it's really about building capacity so communities and health systems can implement change. So that was a very, very long way to really say that IKT focuses on how we create research, to making sure that the questions we ask, the way we study, the way that we design studies, and the results that we produce are shaped by people who will actually use them. It's about ensuring research that is relevant from the very beginning and that it's co-created with your knowledge users. So while IKT is about how research is done, this is a subtle but important shift of what knowledge mobilization is. And knowledge mobilization is about what happens after. How do we share those learnings? How do we move that research into action? How do we make sure that the evidence that we've just created and all the hard work that we've all done doesn't sit, I like to say, on a shelf, but doesn't sit just in a publication, doesn't just sit within academic circles, but actually changes practice, policy, and patient outcomes. So IKT and knowledge mobilization, they're connected, of course, but they focus on different parts of the journey. So one way I like to explain this is like this. IKT is about co-creation throughout the process, whereas knowledge mobilization is about the strategies and pathways to disseminate and implement what you've learned into real world practice. So the image here, I love my images. The image here really represents what I view as the knowledge mobilization cycle, which shows again that knowledge goes through all these multiple steps. And again, similar with the IKT process and the research cycle, it's dynamic, it's non-linear. You go from one area to another depending on what your needs are, your research needs are, your knowledge user needs are. But that's what makes this sort of approach powerful. It's a continuous loop of feedback, right? So research creates evidence, dissemination shares that evidence. We have that evidence to hopefully have uptake and implementation into some sort of action that we're trying to get at. And then this action, if produced and scaled up as we always want, and it's sustainable, it will impact new insights and new questions. And then we come back to the beginning. So now we're here again, and we have a new set of questions that we're trying to ask. And each stage relies on collaboration, of course, between the research team and knowledge users. So both IKT and knowledge mobilization represent different models of co-creating and disseminating learnings. And this is really different than the traditional use of end-of-grant knowledge translation, for example, which focuses on research is done, how do we get it out there? And you typically see this as we all do, and it plays an important role. But in publishing papers, in presenting at a conference, sending a final report or summary, and again, while these are all important and valuable steps, 1000% will agree with that. It's really not enough to create change. If what we're trying to do is create change, just doing an IKT or sorry end of grant approach isn't enough sometimes. So again, I made the image here a little bit bigger. And really it's to highlight the difference between the integrated knowledge translation strategy and then your traditional end of grant. translation strategy. So again, on the left side, where you see it's shaded, we have the process of IKT. And here we're asking, who's leading the research? And again, I'll reiterate, IKT begins by involving partners right from the beginning. We're trying to find the problem. And instead of just relying as us, as experts, as researchers, as clinicians to solve the problem in isolation, you know, involving knowledge users is about co-defining that problem. With respect to research questions and methods, our partners are involved in shaping those questions and deciding on what methods are feasible and acceptable with the community that we're wanting to engage. Again, I've referenced proposal and grant applications, and here knowledge users provide input. They review plans. They ensure that the team has the right mix of skills and perspectives to make sure, again, that what we produce is meaningful and relevant to the communities that we're trying to engage. With respect to collecting data and analyzing data, IKT, engages stakeholders and partners and data collection and analysis to provide insights that sometimes, very, very often, only people with lived experience can offer. So I've mentioned patient partners um, in this work. And of course, on the far right side in the blue, again, just because I love my images, it's what happens in a grant use and often when the product or the research is done. So what I'm hoping that comes across here is that implementing an IKT strategy can be more strategic if done correctly, and it can be done more impactful. So kind of bringing it back to what we do at CDTRP. So Canadian Donation Transplant Research Program, we were funded in 2013 to really leverage that collective expertise in research across Canada by bringing together solid organ, stem cell, and the donation research community. Since 2018, so we've been around for 12 or 13 years. We've gone through various iterations, and since 2013, we've now become a national network of infrastructure to support research, where we can support and promote that interdisciplinary research that's needed through an IKT strategy. And we do this by our research services platform that offers researchers support and grant development, patient partnerships, knowledge mobilization, communications, and event management. But here, what I really want to stress with all those words on the slide, what I really want to stress is, again, that power of collaboration. I always like to say that we, and I mean the collective we, all the staff, all the leadership that's been involved with CDTRP since 2013, we've always strived to really support that multi-level level of collaboration that's needed for innovation, that's needed when we're dealing with high complex systems like donation transplant ecosystem. And since 2013, we have several examples of how interdisciplinary collaboration, one, is not only needed for innovation, but it also makes that research process better. We've had examples where we facilitate synergies, where we've harnessed that creativity, where we've generated new and bold ideas that ultimately impact patient outcomes. And a big part of that and of our KM strategy is really that partnership development, that relationship building. Very quickly, I have on the slide here how our mission focuses on KM. I've highlighted KM there several times, whether it's mobilizing data, whether it's mobilizing knowledge or knowledge mobilization. But really what we're trying to achieve at CDTRP is really driving those advances in research. So we mobilize knowledge so that every wish to donate is fulfilled, and transplantation is transformed from a treatment to a lasting, sustainable cure. And that's across all patients, right? All organs, all communities that we're trying to achieve this. So if advancing knowledge is easy, I've given you the introduction, I've given you the terminology of what we're using. So if it's easy, why aren't we doing it? Why isn't this more effective? Why aren't we all pursuing this? And I'm sure you've all encountered some sort of challenges along the way. Now, one of the most significant challenges from my perspective in integrated knowledge translation and knowledge mobilization is we have a very complex system here in Canada. Here you have an image of our ecosystem. So donation transplant, it just doesn't happen in isolation, right? It's not just a clinician making a time-sensitive decision. It's not just a research study. It's not just a patient's lived experience. Everybody you see on there, and that's just a very quick snapshot of folks involved, but it's a very highly interconnected ecosystem that involves multiple partners, and each one ultimately brings their own perspectives, their own priorities, and their own set of accountabilities to this process. But at its core, as I've tried to outline here, are, I would argue, our patient family donor partners as key knowledge users. And those are patients, those are people directly impacted by the decisions of others in the ecosystem. We have clinicians who provide care and as I mentioned, make very complex, time-sensitive decisions, sometimes on a daily basis. We have researchers who are out there generating new evidence to improve outcomes and guide innovation. We have administrators and policymakers who shape and fund these structures that you see here. We have community partners and advocacy organizations that really represent the lived experiences of our community, but also who are actively, as part of the mission, working to advance equitable access in donation and transplant medicine. And of course, we have our provincial and national organizations who are there to develop guidelines, to implement best practices, and also have a role in accountability. And like I said, each brings a different priority. Each person, each organization here has different expectations. And this is one of the reasons I think that knowledge mobilization can be challenging. Um, when I think of knowledge mobilization, it isn't really just about sharing information or publishing findings. It's ultimately, as I've said a couple of times already, about ensuring that that evidence is integrated into policy and practice and that decisions are made collaboratively. But there's so many moving parts, and as I've referenced, there's different timelines, there's different priorities, there's different ways of understanding data and experiences. And I touched on this a couple of slides ago, but I'll come back to this because we have clinical data, we have patient stories, we have policy outcomes and evaluation metrics, and they all should be viewed equally, and perhaps currently not all are viewed equally, but all of those make an important part of the story that we're trying to show, of the outcome that we're trying to achieve. So really our success depends on creating structures and processes that foster trust, collaboration, and a shared understanding between these groups and many others that for logistical reasons don't fit in one beautiful graph, but that really bring that interdisciplinary view into research. So another significant barrier that I found in knowledge mobilization is a lot of our research, a lot of our evidence sometimes remains just locked within our academic publications. Here, as an image, I've just included a screenshot of the weekly Societo that I receive at CDTRP, and it just shows all the most recent publications from our members. But what I'm ultimately trying to say here is that oftentimes these findings don't make it into the hands of people who will use them most. Our knowledge users, whether it's a policymaker, whether we're trying to advocate for some sort of policy change, or whether it's a community partner, or whether it's a patient who can use this information coming from this new research to empower themselves to make health choices and health outcomes. And I think one of the reasons that, as we've all probably experienced, one of the reasons why sometimes evidence stays in sort of, this journals and academic publications is because there's real challenges we all face. Academic structures, academic incentive structures, right? We're rewarded, and I say again, we, the collectively, for those journal articles, for the presentations at conferences with peers, as mechanisms to get further funding to advance our careers. And what I find yet, and I'm not saying this like a blanket statement, I know there's pockets of evidence where this is happening, but what isn't really happening yet is that, building partnerships, building relationships, which is the key part of IKT and knowledge mobilization, perhaps aren't as rewarded as much as, your academic publications. I've already referenced paywalls. A lot of these articles, that you need a subscription to access them. And it makes it almost impossible for those who need it most to get their hands on it. There's also language and accessibility barriers. So even when articles are open access, sometimes the technical language that's involved in the publications of these might not be entirely accessible to non-academic audiences. And often there's no translation pathway. And what I mean by that is that there's no dedicated step between publishing that paper and then turning that into like actionable real world results. And one of the things I always like to highlight is that, especially for marginalized communities, they might have less access to these. reinforcing those systemic barriers and access to information and access to care that are already experienced. So what this ultimately means is that there's delays. There's delays in implementing evidence. I've heard several numbers, but in preparation for today's presentation, I landed on 17. And one of the articles I read was that it can take up to 17 years for evidence to be fully implemented into clinical practice. So what this means, from my perspective, is that the science exists, the knowledge is there, but the system doesn't change because our academic structures are promoting, again, the publications and the presentations. Knowledge is there, but systems aren't changing, so health outcomes aren't changing. So again, while research and publications are important, they are very important, publishing research is not the same as mobilizing knowledge, is what I'd like to say there. So delivering high quality patient and family centered care really depends on engaging them as knowledge users. At CDTRP, we refer to them as patient family donor partners because that represents the diversity of lived experience unique to donation and transplant. And that's your pre and post patients, that's your families, your caregivers, your living donors, your donor families. And I will argue that they should all have a role within the knowledge cycle. And the evidence is out there. Incorporating PFD partners in research does make for better research, does make for better outcomes. Because without patient partners, again, that research question might not reflect real world needs. Policies may unintentionally perpetuate inequities experienced by some groups. And knowledge mobilization efforts may fail because they ultimately don't resonate with the communities that they're meant to serve. Yeah, I've added this image here and really just to highlight the continued need for research to understand that PFD partners are experts with lived experience in donation and transplantation. And although researchers and clinicians are experts in the disease area, you need both of them. Both levels of expertise overlap, and to do better research, both of those perspectives are required. Because from a knowledge mobilization perspective, right, they ensure that the research, they meaning patient family donor partners, help ensure that research is relevant, equitable, and actionable. And another challenge in advancing research is science is I would argue, a lack of strong, sustained partnerships, specifically with community-based organizations, and especially those who are actively working with equity denied groups. Many of these organizations are the ones at the front lines, providing frontline services, delivering education and outreach to their communities. They're the ones who are building and maintaining trust with populations that are and continue to face systemic barriers in accessing transplant medicine services. And there's several reasons why partnerships with community-based organizations aren't strong from my perspective. I've touched a bit on the traditional research silos where we might work within our own academic institutions, hospitals for research. But of course, one of the reasons because of that, for that, is time, limited time and resources. Building partnerships, building relationships takes time, takes trust, and takes active investment to do that. And I know that's not always easy given, funding realities. To that, funding structures often prioritize, these single year or multi-year projects and don't really, I shouldn't say this as a blanket statement because I have seen some grants available, but don't necessarily prioritize relationship building. So what this means that there's continued lack of representation in the decision-making process. Community organizations are not frequently invited, and their representatives are not frequently invited when priorities are being set and policies are being developed. So this continues to perpetuate this history of mistrust, perhaps that communities might feel. Many equity denied communities have experienced harm or exploitation in health research, and we have several examples. I'm sure we all have examples of articles that we've read that talk to that. So without culturally safe approaches, outreach can continue to be seen as extractive rather than collaborative, right? Researchers going there and doing the research and then leaving rather than trying to build that ongoing partnership. But again, I'll emphasize that community-based organizations are such important connectors to the work that we do and the work that we're trying to achieve, because they're trusted messengers in the community. They're able to advise and provide you with connections so what you're producing is relevant and meaningful to the community that you're wanting to seek. And they also have insights into the local challenges and researchers that, and solutions, I should say, that researchers or research staff or all of us involved in this ecosystem might not necessarily have. So without collaboration, research might continue to fail to reflect the community needs, and your knowledge mobilization efforts might not always reach the right audience. So I bring it back again to CDTRP's mission and specifically highlight that the work we do within knowledge mobilization is collaboration, engagement, and support. And we do this, again, by engaging, by planning, by implementing different strategies to connect these knowledge users that you see on the screen. So our IKT and knowledge mobilization framework really begins by identifying who our potential knowledge users are. And as you are working on a grant or you're prepping for a grant or your research project, really take it back to this root. Who is the community that you're wanting to impact? So we begin by asking ourselves whether the work we're proposing is relevant to patients and communities. And we can really only understand this by integrating persons with lived experience and community organizations into our work. Now, in doing so, our goal is to ensure that the science produced by CDTRP and CDTRP members is, again, relevant and impactful to the communities we are seeking to engage. Here on the second one, you'll see I've highlighted patient foundations on this slide. And really, this is to emphasize the need to build relationships and partnerships with these organizations as well. We're representing patients who are traditionally not involved in research. And again, I want to acknowledge that patient and community engagement takes time, it takes effort. But this is where patient organizations can have a role. These organizations often have daily, weekly, by the hour connections with the people that we are wanting to connect with, whether that's patients that we hope to recruit, for example. But by building relationships with these foundations, we can leverage our collective expertise to help build trust, share findings, and ultimately amplify research in the work that we are wanting to do. So earlier I referenced the traditional end of grant pathways in KT. And again, yes, dissemination of research findings through publications and conferences is important for career, awareness, education. But I would stop and ask yourself, what's the change that we are looking for? So alongside patients and communities, it's really equally important to identify who our other relevant knowledge users are. Now, these individuals or organizations may look different depending on your desired research outcome. So for example, if your goal is to influence policy, your knowledge user might include a government decision maker or somebody in a regulatory body. If your goal is to engage clinical practice, well, your knowledge user might be a healthcare provider or hospital administrator. Now, this type of engagement is distinct, I would say, than engaging with people with lived experiences. So while people with lived experiences bring, critical firsthand knowledge and perspectives, knowledge users within this context often hold positions of power, influence, and authority. So by identifying and involving them early, you create pathways where you can think about that behavior, that output that you're looking for. Is it going to be sustainable? Are we going to be able to implement this? And if you are, and if it's your desire to, are we going to be able to scale this up? So ultimately, successful IKT and knowledge mobilization is just about building those network of voices, those with the lived experience, those providing direct services, those shaping policies, those funding, as I've outlined on my slide a couple of slides ago, because each brings a unique role, and your strategies will need to be tailored to engage them in a meaningful and effective way. Understanding your role, your desired outcome will also help you identify the appropriate channels to disseminate your research. And whether this is patient partnerships, whether it's partnership development, recruitment, or policy change, there's different tools and platforms available for you to use to achieve your outcome. So when you're crafting your knowledge mobilization plan, it's really important to pinpoint very early on what those channels and audiences and messaging will be. So I will quickly go through two examples of CDTRP, how we've implemented an IKT and knowledge mobilization strategy. So the first one I'll start off with is 2021. We worked on a project called the International Donation and Transplantation Legislative and Policy Forum, co-hosted between CDTRP and Transplant Quebec. And what this forum really was trying to achieve is provide consensus guidelines on the structure of an ideal organ and tissue and transplantation donation system. So using our integrated knowledge mobilization approach, we identified Canadian and international experts. We brought together 61 experts, including 14 patient family donor partners, who then worked across 7 working groups. It included clinicians, ethicists, law experts, transplant administrators, and social science researchers. So now together they identified 94 recommendations, which is great. A very robust piece of work. But then how do we mobilize this into a tangible policy change? So through our collective work, we identified a champion in Alberta. RJ Sigurdsson is an elected official from Alberta who had the opportunity to introduce a private member's bill through their previous work with a patient foundation, so in this case, the Kidney Foundation, and with a community-based organization. And again, in this case, the Alberta organization is their name. And he used this opportunity to submit a bill focused on mandatory referral. Depending on your level of expertise within this, some of you might be wondering, hey, what's mandatory referral? But you're not the only ones. So part of the work that we did through our IKT strategy is developing a fast fact, which I've just put a screenshot there, which really a fast fact is a lay and accessible language, a summary, which we then shared with our knowledge users. So we shared it with politicians, government officials, and patient partners themselves to really get an understanding of what mandatory referral was and how this proposed bill would support patient outcomes if passed. Here you see a picture of RJ, and one of the reasons I love including this picture is one of our big wins was when they were debating this in the legislature in Alberta. They took this fast fact that we co-developed with different knowledge users and patient partners, and they read it. They read it verbatim. This was a large piece of evidence that was used in the passing of this bill, which was ultimately passed unanimously. So now, not only did we work with local knowledge users and of course CDTRP and Go Transplant Quebec had a role in facilitating this work, but what really also added legitimacy to our fact sheets was the International Forum really had strong representation from professional societies. So other organizations involved within the forum were the Transplantation Society, Canadian Blood Services, Canadian Society of Transplantation, and the International Society of Organ Donation and Procurement. Within Alberta, we worked with local stakeholders to continue to work with government and hospital administrators to ensure that then when the bill was passed, it had the proper regulatory processes follow to ensure that best practices were reflected. And we continue, the collective we, but including CDTRP, continue to leverage findings from the forum to mobilize knowledge. One of the things I like to highlight is that the forum, the forum to support this work, and I think this is really key, it's not necessarily us, CDTRP, leading this work, but it's giving the tools to others to promote this work. As this slide quickly shows, this is a snapshot of how Kidney Foundation took information, or utilized, I should say, information from the forum and leveraged it to build a website, which is what you see here. They built a toolkit, which was then shared with their supporters. It led to a letter writing campaign to push their MLAs to urge all MLAs in Alberta to pass RJ Sigurdsson's bill. It was I want to say like a month, it was about a 6 or 7 month process, if I recall correctly. But again, leveraging findings that we had. And at the end, I've added this picture because I love it. I've added a photo of all partners and knowledge users involved in the passing of the bill. So here included, you see patients, families, donor families, patient organizations, and community-based organizations shown as all being part of this process that ultimately got policy changed in Alberta. You know what? Maybe I might just pause there because I have another several slides, but I'm being mindful of the time. Rob, maybe I'll look at you. I had another case study I wanted to go through, but I see we have about 15 minutes left.
I think,
I'm at your disposal.
yeah, I think you should proceed, Manuel.
Okay,
Yeah.
perfect. Give me time for a little water break. Okay, so another example of how CDTRP has implemented both integrated knowledge translation and knowledge mobilization is to this project that you're seeing here. So emerging COVID-19 issues and transplantation, but I'll refer to it as treat COVID. So it's been 5 years, believe it or not, since COVID began. And one of the key pieces from the donation transplant perspective is we heard very loud and clear from our patient partners, patients, families, caregivers, of their concerns, of their ongoing questions, of the perspectives, and how COVID would work with them, or how they should navigate, better said, um, the ongoing pandemic. And as you all know, research and knowledge was generating quite quickly when COVID began. There's all these articles that were coming out, but with respect to donation and transplant or transplant recipients, that knowledge was less so. So some of the questions that we heard very early on from our patient community was, what does this mean for my specific organ? What do vaccines mean for me and my overall safety? Are vaccines and other therapeutics effective for transplant recipients? These questions really led the way for scientific research in Canada. So patients and families and caregivers, hopefully and ideally, eventually got responses to those questions. A key part of COVID is regular engagement with the research community, including patient family donor partners, to really understand their issues. On this slide, you can see there between 2021 and 2024, CDTRP held 4 workshops to engage our knowledge users. And the publications are still active and available on our website. But it's really about understanding how priorities were shifting, how questions were shifting as new knowledge came out and as new variants came out and new processes and policies were coming out from both societies and also the information we were receiving from our transplant clinics. Since then, we have gone on to host 4 more national forums led by our patient family donor co-leads to share updates, but more importantly, to continue engaging knowledge users on how their experiences continue to shape informational needs and to really develop an ongoing real-time understanding of their ongoing priorities. This picture here is really just a quick representation to show you what our original plan was, which of course, as we know, working in research tends to change. But it was really an iterative process where knowledge users were involved at all levels there that you see the proposed forums, looping back what we're learning to how we refine our ongoing research. So really what this meant and what we are hoping to achieve or what we are continue trying to achieve is learning from the different experiences of Canada's very diverse transplant population and specifically partnering with communities traditionally not involved in research. For Treat COVID, we specifically identified racialized communities who are experiencing, continue to experience systemic barriers as key partners. So we all know transplant affects everybody. Ethnicity, gender, socioeconomic status, age, any other demographic characteristic they can think of, transplant affects everybody. But to produce results that were meaningful and relevant for all transplant patients, we knew we needed to ensure proper representation from everybody. And like I said, we really prioritize the racialized communities there. This slide here, I've just quickly added to show you how we've proposed working specifically with community-based organizations and our patient partners to refine the research that we've done. Building relationships and partnerships, as I said, really takes time. It takes effort and takes commitment from all involved. And this is especially true working with communities to address complex health issues that are often not involved in research. So I'm going to go very quickly over the next couple of slides, not to discuss the content that's there, but more to give you an understanding and showcase some of the strategies I took when collaborating with community-based organizations. Now, these are organizations that CDTRP or myself or our research members did not necessarily have an existing relationship. It was really who do we want represented in this? Who are the organizations out there representing them? How can we get them involved? And what I'm showing you here, I mean, this is an example of some of the work some of the presentations I did specific with the African, Caribbean, and Black communities. So it's ACB for short, is really showing how our research and our work tied into their mandate. So I'm going to quickly go through here. There's several examples. I didn't name the organization here specifically, but all that work that I just showed you, showing them publications, showing them the research that was already out there, in many instances where they didn't have access to that research already, I was asked to share those research findings with them, is really bringing it back and finding that alignment between the work that we're proposing at CDTRP and the work that they're already doing within the respective organizations. This lended itself to more positive interactions and more positive relationship building. So in this example I'm giving you right now, I first met with them back in like early 2023. And to this date, we're still having those ongoing iterative discussions as Treat COVID continues. Here's another just that quick example of another community that we wanted to engage for Treat COVID, specifically the sexual and gender minority group. And again, this was just another example of a very positive relationship building exercise that we did not have pre-existing, but by aligning our research interests and aligning our approach to equitable healthcare, we've developed these partnerships. As I end in my last couple of slides here, really bringing it back and showcasing the governance model here. So specific to Treat COVID, one of the core strengths in integrated knowledge translation was our approach to meaningful and co-leadership with our patient family donor partners across all stages that I referenced earlier. And this is really represented, I think, through our governance model here. Apologies, it's very short. But our two PFD partners, one representing a transplant recipient, the other representing a caregiver, they've joined from day one. They continue to be part of our steering committee. They continue to inform the direction of the forums that I mentioned earlier. And the key piece here in the relationship building is they expressed and we expressed an interest in working together. Specifically on their end, they expressed an interest in deeper involvement because of their lived experience, because of their expertise already in community engagement and their overall leadership capacity. It's about finding those two-way relationships where their work aligns with what we're doing and vice versa. Now, their roles extended more beyond this symbolic inclusion. As I mentioned, they've helped co-design and co-facilitate forums. They've shaped study methodology. They've reviewed materials. They've co-authored academic and lay outputs. Their presence has helped normalize and open this dialogue by having them involved and others involved, but I'm specifically hiding our two PFD co-leads. But by having different knowledge users involved, it's really reduced those power imbalances and it's built trust amongst the team and amongst the communities that we engage. In doing so, we have found that this IKT strategy has really helped shift from your traditional hierarchies that you see and really positioning patients and caregivers as equal partners and contributors to research. Again, I'm going to show this slide. I'm going to end off with a slide. So IKT, again, is not just about how research is shaped it's not just about how the research agenda is shaped, but it's also about producing practical and community-informed outputs. Again, I bring it back to this slide just to show that the forums that we hosted through Treat COVID help refine our research question, help develop survey content, helped change how we label and how we name the content that we're asking our participants to use, because there was very cultural sensitivities that we were not aware of. They've helped with recruitment strategies. Our PFD partners have been involved in the drafting of lay summaries, our fast facts, and other tools that we've used. And really the forums have served as this mechanism for this continuous feedback, this iterative process that is needed across the research cycle and with your knowledge users. This has really helped us use these learnings for real-time synthesis to get those questions, to get responses out to participants who still care about this. So again, I'll end here. This is one example of how Treat COVID is one example of how IKT has shaped our strategy and how we've applied IKT strategies to address a real world outcome. So I will end there because I know I am vastly over time, but I will stop sharing my screen and happy to take a couple of questions before we close out today.
Thanks very much, Manuel. That was a great talk and really highlights the importance of knowledge translation and knowledge mobilization. And I still think that there's academics out there and there's policymakers out there. And to be an academic without and doing all the wonderful research without actually changing what happens to the patients and families that we look after, I think is you have an empty feeling at the end of your career that, well, I did all this great research, but what did I actually do for the people that I'm actually helping? So this is a really, really important topic. Um, if you have any questions, put it into the chat, raise your hand. But just as we're waiting, Manuel, I mean, many of our fellows and trainees aren't going to be experts in knowledge mobilization when they finish their clinical training or their research training, but are there ways or courses that can help researchers or trainees get better at IKT or KM?
Yeah. There's certainly courses that focus both on community engagement and patient partnerships themselves. Often these are free, and I'd be happy to get some links and share it with you so you can disseminate it with your fellows. But I'll bring it back to that commitment and time investment. I understand that our structure, especially for our fellows going through the programs, like it's not necessarily structured to think about research in this way. And when I reference this traditional knowledge, traditional model of like engaged research, let's call it, um, that is currently incentivized. But I think you need that commitment. And what I have found in speaking with those who have either integrated patient partners or integrated community-based organizations is this understanding of like it can be done, and it actually, like, again, it takes work, but like it can be easy. And showing and understanding through like their own lived experience of how their research has changed and been better. uh like you almost need that experience of I've done this and I've seen the outputs, and now I'm committed to it, right? I like to Right. Yeah. I like to drink the, or I like to drink. I like to use the phrase of like drinking the Kool-Aid, right? Like you need to go through it to see the merits of it. But once you're there, you're there. So bringing it back to your original question, I can certainly share links. Um, yeah, I can share links for free training that's available. Yeah.
Great. Yeah, I think the bottom line is that there are courses out there. So to get better at IKT and knowledge mobilization, definitely take a course if you don't feel comfortable in that. Francis.
Yeah, so thanks, Manuel, for your interesting talk. So I have a question. Like as a basic researcher like myself, we kind of may find it hard to integrate knowledge mobilization, knowledge users into our research process. So do you have any suggestions or advice to facilitate this implementation?
Yeah, that's a really good question. And maybe for this question, I'll bring it back to the role of patient partners in knowledge users. This is a question I've received on multiple occasions. Like how do we integrate patient partners, for example, in the research process? If you're in a lab, if you're working on mice, for example. But one of the pulling it back, what I always encourage researchers to do is to think about what's the output? Like what are you ultimately trying to change here? You're working in the lab because you're trying to fix a health concern, a health issue that people are going through, right? Even that, even connecting, whether it's through an organization or speaking with patient partners, even if it's like in an informal way, it's understanding that just that lived experience of why that matters to help you when you're doing your grant, where you could say, I'm working on this mice because of X, Y, and Z, and this matters because this is what our patient partners are telling us. These are the experiences that patient-facing organizations are going through because this issue, this genetic issue, or whatever the case is here. This is why that matters. So it's not necessarily, um, because I understand your question and some of the concerns there. It's not necessarily involving them in a way that you would in like a policy or legislative change. It's not like that. And I think that's also good to recognize is that each project is different, right? Not each project is gonna require a legislature to be involved in, right? And I think it's just really about understanding what your output is. I said, like, what's the question that you're trying to find? And that's going to inform the mechanisms of how you engage with potential knowledge users. But from a basic science perspective, step number one, like talk to patients. If that's you hosting a webinar to talk about your research, so you can get some perspectives from patients, whether that's in clinic, whatever the case may be, it's talk to patients and get an understanding of why this matters. Good question, though. It's a hard question to answer, again, because each project is, as I like to say, is unique, and there's no cookie cutter mold. Every project is going to have their own knowledge users, for example. Even within patient partnerships and patient engagement, like there's different levels of how patients can be involved, right? And I think matching that to what the project needs are and to what your patient needs are, or your patient partner, I should say, is how you're going to have a successful collaboration. Sometimes perhaps, and I might be guilty of this myself, sometimes it might be, you want to do good work and you want to promise the world, but that doesn't necessarily match what the actual roles are going to be, right? So just being accountable and transparent of what you're trying to achieve is a good first step.
Thank you.
All right, thank you very much. We'll close today. Thanks for that excellent talk, Manuel, on a very